This is Lucas Morton, and today I'm going to be presenting on a quality improvement project. This is a project to improve screening tool usage and to provide objective data from those screening tools that can be used for monitoring and influencing treatment regimens for major depressive disorder and generalized anxiety disorder and the symptoms that go along with those. So, what's the problem? Why do we need a quality improvement project in this area? Well, many patients have major depressive disorder or anxiety disorders, and many of those patients receive treatment from their primary care physician. Not everybody immediately gets referred to a psychiatrist. And in my experience, a lot of times at these, just my experiences being rotations and volunteer opportunities at clinics and working at clinics, that a lot of times patients that are being seen for these types of visits, the physician interviews them, especially for follow-up visits. How are you doing? How's your, medication compliance? And a lot of times the patient responds, I'm doing good, or I'm doing okay, or not so good. And then when the clinician will go to their progress note and document the visit, a lot of times they will put the patient's response in quotes and use that kind of subjective feedback to determine if the patient needs any medication adjustments, how the patient's doing with their disorder, managing symptoms. But my goal with this is to use those screening tools to turn some of those subjective responses that we often get, which are also very important and should be documented, but translate some of those into some numerical scores that could be used in a much more objective manner to look at patient visits, previous visits, current visits, and maybe could be used in some decision-making processes by the clinician, along with, patient presentation on medication dosaging, keeping it the same, changing it, and those types of things. And so with this quality improvement project, we're seeking to increase monitoring, tracking, and documenting mood and anxiety disorder treatment, its progress, and the medication effectiveness in an objective manner through the use of those screening tools at a primary care practice. So, objectivity in the documentation of tracking progress for mood and anxiety disorders is not always as straightforward as other disorders. As I said, you get a lot of subjective feedback with mood disorders. They're not always physical disorders or it's mental health, but it's important to have some sort of objective data, even if it's screening data. And it's important, especially for primary care providers, to have some sort of methodical tool to use because it is one of the most common primary medical care ailments that a patient will present with to their PCP. The stuff I was looking at, research was saying it occurs in approximately 6 to 10% of clinic populations. And so that's a lot of patients that are going to be dealing with a mood disorder. And typically, the two most common are major depressive disorder and generalized anxiety disorder. So those are the two that we were focusing on. And at those visits, patients, there's the list of questions you ask about their mood, their appetite, their sleep, medication compliance, and you get those very subjective, adjective-filled responses from the patient, and you do document those. But to reiterate, I think being able to translate those to a numerical score that you get for each visit that can be compared to previous visits is important and will help the clinician in decision making. So we've talked a little bit about why we want to use these screening questionnaires, but specifically which questionnaires. So the two questionnaires that we're focusing on are the PHQ-9, which stands for Patient Health Questionnaire, and 9 is just kind of the version. And this is the screening tool used for major depressive disorder. And the questions it asks line up to the DSM diagnosis of major depressive disorder, but they're asked in very practical layman terms. A patient is essentially checking off symptoms of major depressive disorder in the DSM-5, but they're doing it through a very approachable screening tool that's phrases questions in a way that are very understandable, generalized. And so the one for the generalized anxiety disorder is actually the generalized anxiety disorder 7. And again, 7 is just the version. And it is similar to the PHQ-9, except it's geared towards anxiety, and it has questions that can kind of hit the DSM diagnosis for GAD. So on this slide, we have an example of the GAD-7. On the previous slide, we had an example of the PHQ-9. They're both very similar in that they ask a series of questions. The patient scores it a 0, 1, 2, or 3, each one corresponding to either not at all, several days, more than half the days, or nearly every day. And then you total the columns and you total the score, and then that correlates to there's a scoring sheet that I didn't put up here, but that correlates to a severity of the patient and where they land on the spectrum of having that disorder or not. Or it could be useful for symptom exacerbation if they have an established diagnosis of one of these disorders. And you're screening them and they're at a follow-up and they score really high, well, then that means that you know that their symptoms currently are not controlled on the current regimen, and then you may be more apt to, again, kind of adjust the medications. And that's really the side that I'm gearing toward for the screening use, is not necessarily to just establish these disorders, but is to use these screening tools on patients with already established major depressive disorder and generalized anxiety disorder, and that these could almost be used as markers for symptom exacerbations or seeing score decreases, and then you know that things are going great, and then you may even want to back off some medication and kind of trial taper. But I believe that these have a lot of potential use in that. So we have talked about how this would help the clinician in decision making, and we have talked about how this can be used to screen for symptom exacerbation or symptom control and things like that. But another benefit to care for the patient is that the ultimate goal is that this feedback will give the clinician the ability to have better control over the patient's symptoms, so that they will have a decrease in the severity, the frequency, and the duration of their mood disorder symptoms. And sometimes they're cyclic, and so episodes can be further apart or decreased in duration. For anxiety, you can have less of a constant anxious hum, kind of at a level, and have that kind of decreased. And so it can screen for things like that, and that is beneficial to the patient, because many times these mood disorders and anxiety disorders very much so affect a person's day-to-day function, practical function, activities of daily living, a lot more than a lot of physical ailments do. And so decreasing symptoms increases quality of life for these patients. So here's my QI study run chart. This is very, very much so an example chart, as I did not implement the project at Three Rivers yet. But this would be for one of the variables, the first variable that showed the percent of eligible patients with PHQ-9 or GAD-7 scores documented in their patient charts or in their progress notes. And so you would see over 6 months, we would want to get higher and higher and higher up to that 100%, but perhaps we didn't reach that in the 6 months of implementing the study, and that's what this would show. We only got to 50%. But you could see if we did it after QI intervention and with no QI intervention over 6 months, no QI intervention, they're not using any, maybe one or two, maybe somebody asked for it. But with the QI intervention, it looked like 50% of the time they were doing it. And maybe one of those fishbone factors were coming into play quite often and preventing that other 50%. So then we would maybe look back at our quality improvement project and see why didn't we get 100%. So, but again, this is just a made up graph, and implementing this, we could get 100% the first time. So we would have 3 of these for each of the variables, and they could show us different, it would give us feedback to analyze and reflect on our QI project. So I think in the spirit of objectivity, it is important to have some standardized or scripted dialogue when implementing this quality improvement project, so that it looks the same to everyone and patients aren't influenced by tone of voice or words chosen or the mood of a specific staff member that day. So I think we could start with standardizing the rooming nurse's dialogue, as she's the one that would provide the patient with the PHQ-9 or the GAD-7. She would see the chief complaint or the follow-up, what they're there for, and then that would cue her in to throw in one of those. I think that only the part where she would be handing the screening to the patient, telling them why they're going to use it, and that they would be back to pick it up and score it. I think all that would be the exact same for every patient. Just again, like I said, so that the patient isn't influenced by tone of voice or words chosen, and that causes them to lean a certain way about how their mood disorder might be going and influence their choices. Project, it was positive, and it was thought that this would be a good way of streamlining follow-up visits, especially for major depressive disorder and generalized anxiety disorder. They thought it was a good idea to translate the subjective into the objective, and that there was a need for that. A big thing was that it could be used to screen for, again, symptom exacerbations of the sort. This project would be physician buy-in to wanting to use the PHQ-9 and GAD-7. Many have been in practice for a while and have their routines, and add in something that would only take up a little bit more time but still take up time might dissuade physicians from doing that. And here I talk about how you could explain to physicians how you may persuade them, and I talk about how you can you can bill for the screening. Another one would be patient buy-in to complete the screening tools every time. I think you would just explain to them that it's being used to track symptoms and how their disorder is progressing. The rural health implications of this quality improvement project. We know rural health is plagued by a lack of healthcare providers, let alone specialized physicians. So there's even more primary care physicians treating psychiatric disorders like major depressive disorder and generalized anxiety disorder that this quality improvement project would be very useful for. It would give somebody that might not have a methodical approach exactly that to use to approach patients and influence decision making. These are my references, and this concludes the presentation.